Good morning, everyone. My name is Rikita. I'm the internal medicine resident. Can you guys hear me? Can you guys hear me properly?
Yes, you sound good.
Thank you very much. So I'm going to start my case presentation. It's a rare case of cardiac fibroelastoma, which was a cause of embolic stroke. So I would start with my case presentation. A 73-year-old female came with history of found unconsciousness for unknown duration one day back. Patient was living with her daughter, and her daughter went for work in the morning. And during that time, patient's mother was doing fine. But when the patient's daughter came back in the evening, she found her mother lying on the floor, unconscious state. She did not know patient for how much duration she was lying unconsciousness or what happened. Nobody witnessed that event. Patient's past medical history is significant for diabetes mellitus, hypertension, septic arthritis, right knee, and gout. The patient was brought to a different hospital from where she was referred to our hospital for further evaluation. On presentation, her significant vital signs were her blood pressure was elevated with 180 by 82 mm mercury, and she had a temperature of 104.1 Fahrenheit later during that day. The significant findings were her neurological examination showed that patient was drowsy during that time, but she followed commands. Her power was 4 by 5 in right upper extremity and left lower extremity, and 2 by 5 in left upper extremity and right lower extremity, which was limited by pain in left shoulder and right knee. So after her presentation, our most probable DDs were cardioembolic stroke versus septic cerebral emboli, for which the workup was initiated. Her CT had showed that multifocal areas of hypodensity throughout both cerebral hemispheres and cerebellum, suggestive of subacute embolic infarcts. Her MRI brain showed multifocal bilateral, cerebral, and cerebellar acute infarcts with associated petechial hemorrhage, mild enhancement of bilateral parietal infarcts. I have posted the picture of MRI brain. On the left-hand side, this is the diffusion-weighted imaging MRI. And here on the left basal area, this is the white lesion. And on the right upper frontal area, this whitish lesion for the embolic infarcts. Similarly, on the right-hand side, this is the ADC map imaging MRI. And at the similar area, we can see this is the blackish area lesion on the left lower corner and the right upper corner, the similar areas. And these were suggestive of the embolic infarcts. Then we also did a CTA head, which showed 60% proximal right ICA stenosis and 40% proximal left ICA stenosis. We did blood cultures, which were negative. Then we did a TTE, which was unremarkable. Then we did a TEE, transesophageal echocardiogram, which showed normal LV systolic function, no ASG, no VSG, no PFO. Her ejection fraction was 55 to 60%. There was no evidence of vegetation. There was no intracardiac clot. But it showed that aortic leaflet, left coronary cusp, has a suspicious fibroelastoma. Then we requested for a cardiovascular surgeon consultation, and finally patient underwent exploratory cardiotomy and excision of that aortic valve mass. That mass was sent for pathology, and the pathological report confirmed that mass was a benign papillary fibroelastoma, which was a tumor of aortic valve. I have posted the histological image of that slide, and here we can see the papillary projections confirming the benign papillary fibroelastoma. Then patient's post-operative period was complicated by right lung atelectasis, right-sided pleural effusion, hypoxic respiratory failure, AKI, and new onset paroxysmal AF, which were appropriately managed. Patient was finally discharged to the rehabilitation center on aspirin and statin in a hemodynamically stable condition. So the learning objectives from my case are: we should consider papillary fibroelastoma in the DD while evaluating for cardioembolic stroke. The role of antiplatelet and anticoagulation is still not clear in this, and further studies are needed to establish this. Study done by Tamin S. et al. Showed that papillary fibroelastoma is the most common benign cardiac neoplasm of adulthood. There are many studies which showed that cardiac myopsoma is the most common, but this study was the largest study till date when this study was published regarding the frequency of PFE, and the follow-up of patients. And they showed that PFE is the most common benign cardiac neoplasm of adulthood. They also recommended that patients who are good surgical candidates with left-sided PFE, regardless of size, mobility, or location, a surgical excision should be considered. There are few studies which showed that on the left-hand side, PFE, especially with the symptomatic patient, they should be undergone surgery. But right-sided PFE, especially with the asymptomatic patient, the data is still not clear whether we should go for a surgical excision or whether we should start antiplatelet and anticoagulation. And the role of antiplatelet and anticoagulation is still not clear, and we need further studies to establish this. Thank you very much. Any questions?
Alrighty, great. Thank you, Rikita. Do we have any questions out in the audience? Alrighty, I do have one question. So following excision of the cardiac mass, is there any data on subsequent stroke risk in these patients, maybe in other studies, or is this pretty novel?
So the other studies that I underwent on PubMed and the other database, I saw that stroke and transient ischemic attack is the most common presentation of cardiac papillary fibroelastoma. It is not diagnosed usually until patient comes with some symptoms, and the stroke is the most common. And our patient also presented with a stroke, and like after undergoing these evaluations, we found the diagnosis of cardiac fibroelastoma. But studies showed that if it has been after surgery, the patients have very good outcomes. There has not been recurrence of stroke after a surgical excision, and they have very good outcomes after surgery.